Will you turn off one of those lights back there so it's a little bit clearer up here, whichever one works better? That'll work. Yep. All right, so we are recording today, and so what I'm going to do is I'm going to make sure we're going to get through part of this, and then I'm going to let you guys go because I want you to get wherever you want to go to try to see the eclipse. We're moving into an important part of pharmacology in that it is talking. We're going to talk about pain management medications, and so pain management is really important as a paramedic because in the past, we've been really hesitant to give patients pain medicine because of, quote, maybe they're just a drug seeker. You may be able to identify that when you are taking care of a patient, but most of the time you won't be able to. And because of that, what I would tell you to do is don't be afraid to treat your patients for pain if they are having some type of pain, and especially once you've assessed your patient and evaluated them based off of the mechanism of injury as to what's going on with them, don't be afraid to give them the appropriate medicine. Now, here's the other caveat that I'm going to share with you. As we've seen, particularly out in Colorado, 2 paramedics have now been convicted of a crime where they oversedated a young man. This was sedation, not pain management. And part of the reason was, I believe, they inaccurately estimated his weight. I think that has been in the past kind of a big emphasis of, I want to give ketamine, I want to give ketamine, I want to give ketamine. And that's not healthy either. The thing over here is saying, let's withhold pain medicine unless they absolutely positively need it is not healthy. It's not good medicine. And the opposite extreme of wanting to give medicine just to say that you've been able to give it is not healthy or not good medicine either. And so basically what we're looking at here is this: we're going to be talking about both analgesics and sedatives in this particular section of it. Now, we don't do an entirely really good job of pain management pre-hospital wise. Think about it this way. Let's say your grandmother or your grandfather falls and they break their hip. That's one of the most painful injuries that they can possibly have. And now they've got to take a 30-minute ride between their house and the hospital. And trust me, in the back of an ambulance, ambulances are not built for comfort, they're built for emergency care. That's going to be excruciating for your patient. And so when you are able to alleviate that pain, that's going to be incredibly important. It's going to be incredibly compassionate. The other side of this is going to be also in certain situations, such as when we're dealing with patients that are having MIs, reducing the pain also reduces the possibility of our patient having permanent damage to their heart, because their sympathetic nervous system, those of you that were in 303 know where I'm headed with this, sympathetic nervous system is now dampened down, cardiac workload is now lessened, and as a result, we don't have nearly as much damage for the heart as what would possibly be on there. One of the things that we need to understand is that there's a difference between an analgesic, which is pain relief, and a sedative, which is given to diminish or to help a person to either, number one, relax and calm down, or potentially to forget what you're going to do. In sedatives, we have types of sedatives that are known as hypnotics, and we give that to help them to also lessen the pain of a procedure that we're going to do, but also not to remember the pain that they experience. So, for example, if we got a patient that is in SVT, one of the treatments that we can give this patient is that we can cardiovert them. It involves running the electricity through their chest It cardioverts the heart, and the purpose of it is to slow the heart rate down to where it's a more perfusing rhythm. It feels like, I've never had it done, but I've seen it and done it to several patients, but it feels like you've been kicked in the chest by a horse. It is not pleasant, bless you. It's not pleasant at all. So one of the things that we do is that we don't really want to give pain medicine just yet, because generally when we're going to cardiovert a patient, their blood pressure is already low. One of the things that pain medicine will do is it will drop your blood pressure even lower. That results in poor perfusion to the brain, the heart, and to the kidneys, as well as to the rest of the body. But we can give them a sedative so that they relax and they're not able to remember the pain that they experienced. And both of these are very humane, very compassionate approaches for what we're dealing with our patients. Now, for the most part, the types of analgesics, and again, it amazes me. I work with a lot of students from around the country who struggle to pass either their EMT or their paramedic national registry exam, and it amazes me the number of students that don't know what the word analgesic means. Analgesic is just simply another medical term for pain relief. Analgesia is the same thing, pain relief. Most of the meds that you're going to utilize, that you're going to give for any type of pain relief, are going to be opioids. Why do you think that might be? Why do you think that most of the pain meds that you're going to administer are going to be of a narcotic base? Not all of them, but most of them are.
Well, it has to do with the transmission of pain signals.
You're exactly right. So basically, opioids work in what part of the body?
The opioid system,
And that's located where?
all throughout the body.
It is, but the primary receptors are right here. So this is why when we give an opioid, if we give a little too much, and sometimes we want that, your patient loses consciousness. Okay? In essence, this is the thing to remember. If I break my arm, I begin to experience pain. The pain that I'm actually experiencing is not occurring at the break, although based on the way the brain sends and receives signals, we feel that pain when we move the arm and it's broken, we hurt it. But we actually feel the pain in our brain. So when we give a narcotic, another name for an opioid, what that does is it diminishes those opioid sensors' ability to sense and relay pain to the brain. And so that's why it diminishes it. The other thing is that narcotics, when given either IV, especially IV, or IM, not as fast, they have a very rapid onset, which is what we want. We don't want our patient to suffer in pain any longer than what they absolutely have to. So basically what we're looking at is we've got several different types of opioid receptors that are found within the body, but the most important ones are going to be found within the brain. Now, here's the thing I want you to remember about the administration of narcotics. Almost all of them cause a drop in the blood pressure, okay? Now, what kind of patients do we need to be really, really careful on as far as we don't want to drop the blood pressure on them?
Shock.
Any patient that, number one, is in shock, or number two, we feel like has a good propensity of going into shock, good answer, we want to be very, very judicious about the administration of a narcotic. Now, that does not mean that we're not going to give something for pain relief. One of the nice things about paramedicine today is that your repertoire or your arsenal of pain relief medications is expanding every day. When I was sitting where you were at, the only pain medicine that we had that we could give was morphine, which is going to be the first one that we're going to talk about in just a second. We were really limited in the patients that we could give that to simply because of the negative side effects that it can have on a patient's hemodynamic status. So let's just kind of jump in there and let's take a look at morphine. Morphine is known as an opiate agonist. Now let's go back to the beginning of class and somebody remind me what the word agonist means. Say it again.
Turn things off.
Not off, on. So an antagonist, A-N-T, or anti-agonist would turn things off. It would block things, okay? So an opioid agonist, an opiate agonist basically says it links up with the opioid receptors in the brain, and because of that, it makes them to begin to work. And now our patient begins to have a decreased sensation of pain. Now, let me ask you a question. Somebody knows this one in here. Give me an example of an opiate antagonist. Narcan, yeah. Narcan goes and attaches to the opioid receptors in the brain, and it blocks it. Not only does it block it, it forces the opiate off of those receptors. And as such, now what's going to happen is our patient now regains consciousness. Now, here's the thing about morphine. I want you to know this, all right? Morphine basically does a couple of things to drop the blood pressure. Number one, morphine will come in and it will depress the vasomotor center of the brain. Now, when we talk about vasomotor, motor means action when we're talking about the body, okay? Vaso refers to the vascular system. Remember we talk about vasoconstriction or vasodilation. When we say the vasomotor center, we're talking about that part of the brain that causes the blood vessels to constrict when the blood pressure is low and to dilate whenever the blood pressure is too high. When it comes in and it begins to attach to the opioid receptors of the brain, it also attaches into those vasomotor centers of the brain, and in essence turns them off. Okay, and as by turning the vasomotor centers off, this is what happens to your blood vessels. So when your blood vessels dilate, what happens to your blood pressure? It drops. It decreases. You're exactly right. That's not all that it does, though. Morphine will release a chemical neurotransmitter known as histamine. I dare say every single one of us over the last few weeks have been dealing with histamine. The well-known part of histamine is when the flowers begin to bloom and the trees begin to get their leaves and we get pollen in the air. Now we begin to get sneezy, snuffy, coughy, sneezy, and all that stuff. You get hoarse. You begin to sound kind of like I do right now. And so the histamine does what? It also helps with vasodilation, but the second thing that it does is it causes little holes to begin to develop in the vasculature, and the plasma, the liquid portion of the blood, begins to leak out. So basically what happens now is even though our arterial system was this size and it was full of blood, and we had a good blood pressure, when it does this, if we have the same amount of blood, the pressure is going to drop, but we don't have the same amount of blood anymore because it's beginning to leak out. And so again, it's critically important for you to remember that the histamine release and the vasomotor action or the blocking of the vasomotor action on the brain causes this to come into play. Morphine is a good drug that we can utilize in the treatment of angina. Okay, angina, as we've been talking about in 303, comes about as a result of an inadequate supply of oxygen for the workload of what the heart needs. As a result, the heart begins to have discomfort, pain, pressure, whatever the patient describes it. It's also really effective for that same pain that now comes about as a result of a patient having an MI, when the blockage is complete and there's no blood moving through. When we give our patient morphine, it reduces the pain. When a patient has chest pain, they begin to get anxious. They get nervous because they know they're having a heart attack. You can die from a heart attack. And now their sympathetic nervous system begins to work fast. Heart rate goes up. Blood pressure goes up. And now the heart requires even more oxygen, Rebecca, than what is available. When we give them morphine, we take the pain away. The patient recognizes that as, oh, I feel better. I'm not hurting like I was before. I must be getting better. In reality, the problem has not been resolved. The blockage is still there. We have to take care of it. But what we've done is we bought our patient some additional time of not destroying heart muscle. Because remember, time equals muscle. When we're talking about the brain or the heart, the more time that goes by that we don't get our patient into a cath lab, the more heart tissue or the more brain tissue that dies off. And that tissue is not coming back. So what we want to do is we want to reduce the workload of the heart by giving our patient morphine. It helps to do that. It does that by reducing the rate, the workload, as well as the O2 consumption that the muscle requires. So what are our indications for this? And I will have PowerPoints handed out or hand out for you on Wednesday for this entire module. I only copied one. I ran out of time before I could make additional copies. Morphine is good primarily when we have a patient that is having chest pain. Now, we don't generally use a lot of morphine now for trauma. We've got other types of opiates and other types of medicines that we can use that don't have the same negative impact on the blood pressure as does morphine. So generally what we're looking at here is that we would give it for relation of cardiac, some type of cardiac chest pain. The other situation that we may want to consider utilizing this in is that in patients with congestive heart failure. Now in 303 currently we've not talked about heart failure or congestive heart failure, whichever way you want to call it, but we will. But that heart failure comes about as a result of we have a large portion of the left ventricle that no longer works. It's died off. And again, remember, when it dies off, it scars, it doesn't pump, it doesn't conduct electricity. And so it doesn't move as much blood out through the body as much as it could. As a result, that blood begins to back up into the lungs, resulting in what's known as pulmonary edema. We listen to the lungs, and it sounds like air that's going through water. Okay, you hear that popping and that crackling and that snapping noise as the air is coming in and trying to mix in with the alveoli, which are full of fluid. One of the things that is good about morphine sulfate is that, again, remember I said it causes vasodilation and it causes plasma to leak out through the blood vessel. If we give them a small amount of this, if they are in heart failure, that's going to reduce the amount of blood that's coming back to the heart, and it's going to reduce the volume of blood that will now back up into the lungs. Why? Because the pressure has dropped and some of the fluid is coming out of the blood vessels. It's a tightrope that we have to walk to be very, very careful as far as that process goes. So these are your adverse effects. Number one, respiratory depression. It's a narcotic. If you give too much, your patient will stop breathing. Okay? That's why when we're giving pain medicine, especially medicine that is a narcotic, we want to start low, and we can give multiple small doses until we build up to where we've got the therapeutic window working well, of where a patient's pain has been relieved or managed. And by relieved or managed, what I mean is that the pain may not be completely eliminated, but it's managed, it's reduced enough, but our patient is still able to maintain their own airway. The other thing about respiratory depression, as well as hypotension, is that if you give it too fast, it will speed up that process of dropping it down. Also, if you give it too fast, the third item on that bullet list now begins to develop and to become more prevalent. Nausea and vomiting. Now, why is nausea and vomiting always a concern for us if we're giving a narcotic?
Airway.
Tell me more about airway.
They can block it and they can't breathe.
Yeah, because remember, what's one of the side effects of giving a narcotic? Besides nausea and vomiting, what can it cause them to do?
Loss of consciousness.
Loss of consciousness. And when a patient loses consciousness, now they lose the ability to effectively manage their airway. And so if we give it too fast and our patient begins to vomit, what we've done is we've made a bad situation worse. Okay? So when you're giving morphine, this is not one of those situations where I would tell you to go ahead and get your suction unit out and get it ready and have everything ready. But I would tell you, make sure you know where it is, where you can grab it if you need to very, very quickly. It can also lead to sedation. So your patient can go to sleep. They can become unresponsive. And again, this is not what we want when we're administering morphine. We want pain management for this. Contraindications. These are your contraindications that you need to be able to tell me. Number one, if your patient has any type of respiratory depression, if their respiratory rate is really, really slow, now we don't want to do that. That's because we're going to make it even slower. We don't want to give it to a patient that's in shock, okay? And signs and symptoms of shock would be an elevated heart rate with a lowered blood pressure. This is only going to make that situation even worse. Now, the last one there, basically those are relative contraindications. Respiratory depression and shock are absolute contraindications. Absolute contraindications means we're not going to give it no way, no how in those situations. In these, what we're looking at, especially when we're dealing with patients that have asthma or respiratory insufficiency, what we want to do is we want to be really, really careful and just really, really start out with small doses. Why? Again, because that respiratory insufficiency may be coming about because they're breathing too fast. Okay, so they're breathing too fast. The reason we want to be careful in giving it with patients with head trauma is that one of the most important things that we can do for our patient is to make sure that we're able to do an assessment on our patient in a head trauma to see if there is any deterioration. If we give our patient a bunch of morphine and now they're unresponsive, guess what? We're not going to be able to do a neurological assessment on them. So again, it's not an absolute contraindication, but it is a relative contraindication of saying, let's just start with a really small dose and be very, very sparing on it. So how do we give it? So generally, morphine comes packaged in a preloaded syringe, and we will give between 2 to 4 milligrams at a time, and we can give up to 10 milligrams. So we can repeat this. Generally, what I like to do is, again, depending upon the patient's size, depends whether I'm going to give 2 or 4 milligrams. If you're giving me morphine for chest pain, for an MI pain, generally what I would tell you to do is you would start out with 4. If you're going to start out with somebody who is a smaller size, go ahead and start out with 2, and then we can repeat that generally about every 10 minutes until we get pain relief. Now, here's the thing to remember. If we're giving it IV or IO, IO is directly into the bone, the onset is generally going to show up in about 3 to 5 minutes. So make sure that you've got some time separated between your doses to allow this to begin to come in and to begin to actually work. Here's the other reason why we want to be really careful if we're administering to a patient with a low blood pressure is that you got to remember the circulation is much, much slower in patients that are in shock. So if we give a drug of say like morphine and we give them 2 milligrams and we wait 5 minutes and we give them another 2 and we wait 5 minutes, and then all of a sudden, for whatever reason, all that medicine now finally arrives at the brain. The brain, in essence, is actually getting about 6 milligrams at one point in time rather than the 2 milligrams that you gave 5 minutes apart. So you want to be aware of that. We can give morphine IV into a vein, IM into a muscle, or IO into a bone. We'll talk more about what IO means a little bit later on. And so it goes in and it works fairly well for either one of those. Watch your patient's vital signs. This is something that is critically important, ladies and gentlemen, that when you do a treatment, whether that treatment is you're giving morphine or you're splinting an arm, you need to reassess your patient after every treatment. Some treatments have specific assessments that you've got to do. So, for example, if we put a splint on a patient's arm, the last thing we want to do is to have that splint so tight that it's cut off distal circulation. So we want to go back and we want to assess the pulse, the motor, and the sensation. Can the patient still feel after we've put that splint on? The assessment that you want to do for these patients as far as your vital signs and things go along that line is that you want to look at your patient's pulse, you want to look at your patient's blood pressure, you want to look at their respiratory rate, and you want to watch their pulse oximetry. Pulse oximetry is the little clip that goes onto the fingernail, or in children, we can attach it to the earlobe or to the big toe. It is assessing the percentage of oxygen that is attached to the hemoglobin just underneath the skin. Normal, 94% or higher. So when we're giving morphine, we want to make sure that we've got that pulse ox on our patient and we're watching that pulse ox as we are giving it to them. For 2 milligrams, one of the things that you can do, particularly if you're drawing it out of a multi-dose vial, is you draw up the 2 milligrams, and generally 2 milligrams will be in 1 milliliter. And then I would tell you to go ahead and pull up another 5 milliliters of normal saline to dilute that. You're able to give that much slower if you're administering 7 milliliters of fluid than you would if you were only administering 1 milliliter of fluid. They're still getting the total dose of the morphine, 2 milligrams, but it's been diluted with an additional 5 milliliters of fluid for a total of 6 milliliters of solution that's going in. When you give this solution, the patient may complain of either kind of like a hot flash, or sometimes patients will say it makes them feel irritable. Okay, that's the histamine release that is occurring. So again, the way we minimize that is that we give it just a little bit slower. If you have a patient that now becomes unresponsive and they're able to they're not able to maintain their respirations, now what you want to do is you want to treat that with Narcan, okay? Caveat here. If you're giving morphine for chest pain, most of the time you're going to be given something different, but you may give morphine. You want to try your best to only give enough Narcan to bring the respiratory rate back up in a heart attack patient. Why would I say that? Why do we not want our patient going from completely unresponsive to blocking out all of the effects of the morphine at one time?
That will activate their central nervous system and increase their pulse work rate.
Exactly what you said. So in an instant, because Narcan works really, really quickly when it's going to work, and it works most of the time. But in an instant, basically what we've done, if we've gone from a patient that's unresponsive, now we've gone back to a patient that has severe chest pain that's going on. And as a result of that, now we've increased the sympathetic nervous system, we put an increased workload on the heart, and now because we have not done the right thing, we've caused our patient to have more damage to their heart. Okay? Questions on morphine? The drug that you will give quite frequently for both trauma as well as for cardiac disease is going to be fentanyl. Now, fentanyl is a narcotic as well. It binds to the opiate receptors just like morphine does, and it will cause a patient to have pain relief or analgesia. The indications that we utilize this for are going to be, again, for pain that's related either to chest pain from a cardiac problem or potentially pain from trauma, okay? You still have, because it's classified as a narcotic, you still have the same issues that you have with respiratory depression and potentially dropping the blood pressure, as well as, especially if we give it too quickly, nausea and vomiting. Again, the incidence for narcotics of going up and causing respiratory depression also increase the faster that we give it. We want to be careful, again, because of traumatic brain injuries. The other reason I forgot to tell you as far as morphine, and it's the same reason for this, is not only does it cause sedation, and it leads into a situation of where you're not going to be able to assess your patient. But remember, what did I tell you narcotics do to the arterial system when we give it to them? Does it dilate or constrict? It dilates. Now think about this for just a minute. If we've got brain trauma, one of the things we're really, really concerned about in brain trauma is swelling and pressure in the brain. If we take our blood vessels, take all of our arteries in the brain, and we give them medicine that causes them to go from like this to like this, will the pressure inside that tissue go up or will it go down? You got a 50-50 chance. You got a reason, or was it a yes? Because you're right.
Because the fluid is still in there, it's just
Not the fluid. Now think about it, okay? Let's imagine that we've got a sponge here, okay? And we take a 1 milliliter catheter and we thread that through it. Let's say that through magic, we're able to make that 1 milliliter catheter that is in there, that tubing that's in there, we make it 4 milliliters now. What's that going to do to the pressure that catheter exerts on the sponge? It's going to increase it. So if you've got millions and millions of little arteries and arterioles in the brain and we cause that vasodilation, it's going to now begin putting more pressure in the brain. And when we put pressure on the brain, what do we do to the cells? Technical term here is we squish them, okay? They get squeezed and eventually they rupture. And again, those brain cells now begin to die. When they die, they don't come back. Your dosing for fentanyl is going to be 50 to 100 micrograms. So, looking at your dose of fentanyl as opposed to your dose of morphine, which one of these drugs do you think is more powerful? Fentanyl or morphine?
No.
Fentanyl, without a doubt, fentanyl. So we get much smaller amounts, okay? Generally, what we want to do is that we want to pull this up, dilute it, and you can see we're going to give that medicine over 1 to 2 minutes. By doing that, that's going to help resolve any problems that we have with our blood pressure. It's going to help prevent any problems with nausea and vomiting, and it's going to help to prevent any problems that we're going to run with as far as loss of the ability to breathe. Okay? All right, so I've got 204 right now, and I'm going to stop there so we can